Welcome to NDCPD's second collaborative webinar series. While you guys are waiting, please add your city and state in the chat so we can see where everybody is from. For those just joining while we're waiting, please add your city and state in the chat so we can see where everybody is from.
Krista, did Daryl Wall get in the room?
Yes, he did.
Okay. Well, I was trying to do his and mine at the same time, so.
Okay, so again, welcome to NDCPD's Collaboration for Change webinar series. My name is Vanessa Rovig, and I'll be your facilitator for today's webinar. We're so excited to be hosting this event again this year. Last year, we had sessions about disability trends, customized employment, and other disability-related topics, and we were excited to see so many people interested in take part this year. For those of you who are familiar with NDCPD, great! For those who aren't, we're a University Center of Excellence on Developmental Disabilities, also known as the UCED, and we're a part of a national network of 67 other UCEDs throughout the United States. We serve the North Dakota disability community by providing training, technical assistance, services, and information. We have approximately 15 to 20 projects at NDCPD that cover a range of topics connected to disabilities: employment, housing, education, and early intervention, to name a few. We're also excited to announce that this is NDCPD's 35th anniversary. More to come on that throughout the year. You can check us out at www.ndcpd.org. Today is the second webinar in a series of 5. NDCPD is hosting today's event as an informational exchange on specific disability topics. With this event, we hope to build a community of individuals and agencies with a common interest in disabilities. We're excited for today's event and hope you enjoy today's presentation. First, we have a couple housekeeping notes. We will be recording today's event, and the recordings will eventually be available on our website. We'll have time at the end of today's session for Q&A for our presenter. To get your feedback on today's session, we will have a short online survey. The link for this survey will be in the chat at the end of today's session and also emailed to you after today's session. We appreciate any feedback. Up to 5 contact hours will be available for social work or nursing, depending on how many sessions you attend. If you want contact hours, you must complete this online survey. As well, contact hours will only be granted to those who attend the live sessions. Watching the recordings after the fact will not count towards contact hours. This is different from last year. So with that, I believe we're ready to get things started. Today's webinar is titled Aging in Place. Today's presenter is Dr. Tamar Heller, Director of the Institute on Disability and Human Development from the University of Illinois, Chicago. And now we will turn the attention over to our guest speaker. Welcome, Dr. Heller.
Mute. 1 second, I'm just sharing. All right. Do you see my slide? Yes?
Yes, we do.
Oh, okay. All right. You know what? I think I'd rather have you do it so I can see it on my main monitor. Let me stop share.
Krista, are you able to pull that up?
We'll just get 1 second. We'll get that pulled up. Yep.
Yeah, it's just easier. Okay. Great. And then I can, oh, you'll be moving it. Okay, great. Welcome everyone. I'm from the USED in Illinois, and I'm really delighted to give this presentation. I was just telling people I presented on aging quite a few years ago at your center there when you had some special aging initiatives at the time. So it's exciting to be able to do this again and all the new things that have been happening in the field. Next slide. Just to give a little historical perspective of how we deal with the aging of people with IDD, which I'll be saying for short, IDD, and how it fits with the kind of zeitgeist of how things are changing in the field. When we used to present on this, we used to talk about the specialized aging corner of segregated centers and, you know, making senior programs and following all the things that they used to do and they're still doing senior centers. Then we talked about taking people to senior centers because age appropriate was part of normalization, right? So you basically would take a bus load over there. And of course, then there were live initiatives to make it more individualized as person-centered planning for later life became sort of popular way. And we started developing and other people person-centered approaches. So maybe some people wanted to go to senior centers. And then really thinking about being part of the community. And that's combined with person-centered. And since 2006, we've been very much focused on the human rights aspects and the rights of people. Next slide. So what do we mean by successful aging? You'll hear about this. Often it's aging without a disability. Well, how does that work when you already have a disability? In fact, I'm editing a special issue of the Gerontologist right now on bridging aging and disability. And lots of the articles are talking about some of these issues. we know there's a lot of ableism about, aging without a disability. But also, the whole thing about staying youthful, there's a lot of ageism as well. And we talk about compulsory youthfulness, which actually one of my graduate students kind of coined that term in Gibbons. And it really has to do with the fact that somehow you have to stay young. And there's kind of an intersectionality with disability studies and how we think about ableism and ageism. We think about old disabled as somehow being failures. Oh, you ate too much, you became obese, you didn't exercise, you didn't do this or that, you smoked. As if it totally depends on one's choices and efforts. But what about the state's responsibility? What about the opportunities people have? There's many other aspects. Next slide. So how do we address it? First, we want to get the perspectives of people with disabilities. And we want to adopt empowered frameworks, looking at interdependence versus independence, how people feel about their identity, but not to forget to take in the role of minority status, poverty, culture, or a life course approach. What you do early in life and what happens to you early in life can affect how you are in aging. In fact, there's even some research that shows that when a woman is pregnant, some of what she does, whether he or she, when they're pregnant, what happens to people later when they're aging. So just some interesting aspects as we think of the life course approach. Next. So what do we mean by healthy aging? Living on your own terms, adding value to society, family, or friends, and maintaining health and function. This is the way I like to think about healthy aging. Next slide. I'm sure that most of you have heard about the life expectancy often being lower for people with IDD, and that is true for many, but often it's very similar unless they have severe levels of cognitive impairment. Down syndrome tends to be earlier and earlier age-related changes, cerebral palsy, and multiple disabilities. Next slide. But we also know the life expectancy has improved so much over the years, especially if you look at Down syndrome, where many of them used to die in their first year, often because of their heart conditions. So let's look at the interaction of aging and IDD in life transitions, which is how I like to think about it. And as people get old, they develop chronic health conditions. We have changes in the family caregiving supports. As families, parents pass away or people move out of the household. We have retiring from employment. Again, it's kind of different for people with IDD, men who never were employed or worked in a more sheltered kind of situation. And then the whole issue of end of life care and how does that work for people with IDD? Next slide. So I'm going to talk a little bit about the health of people with IDD without great detail, because I kind of want to focus more on what we do about it, but I think we want to give some context. There's a lot of research about this. We do know generally there's poor health and earlier age-related conditions. For example, dementia. We see that dementia and Alzheimer's disease often occurs at least 10 years earlier for people with Down syndrome, for example, including other age-related changes. Osteoporosis is very common, and much of that is due to the medications that people take, for example, for epilepsy. Oral health can be related to your heart condition. If you have you have infections, it can affect it. And diabetes is another one where we see some greater diabetes. We also see higher rates of falls in this group. Next slide. Much more obesity that we see, and much of that is due to sedentary behavior and unhealthy diets. And there's many reasons for that. And sometimes it has to do with the fact that people may eat like the same food all the time, or we have a picture here of a couch potato, and all that gets related to what happens later in life. Next slide. So some aspects that relate to the access to healthcare. So we know there's a diagnosis of cancer at a later stage, which means that they're more likely to die if they do get diagnosed with cancer. There's a lot of polypharmacy. It's not uncommon to see over 10 medications for people with IDD, and especially as they get older and more medications. And there's also been some research that shows there's deaths that are amenable to healthcare intervention. They would not have occurred if they had the proper healthcare intervention. And we do know about our healthcare system being the best and the worst, depending on how much you're able to access the good healthcare. The lack of testing and treatment for COVID-19 was really, it showed some of the access barriers, as people had difficulty communicating symptoms and understanding the instructions. We've had rationing, prevention of the support person at the hospital. I had that experience. I have a sister with disabilities. I'll tell you more about that. And I wanted to visit her. I'm her health proxy. And she was in a life and death situation, and they wouldn't let me in. And I said, you know, why can't I go in? Because some staff person had been there earlier in the day. And I traveled an hour and a half to the hospital to see her. And I played the doctor card, and they let me in. I'm not a physician, I'm a psychologist, but they fell for the doctor card and let me in. So, but that wasn't really fair. You need to know your rights and that there's equal access and support. And there were some changes during this time to allow support people to come in during this whole COVID time. Next slide. And we know they had a greater susceptibility to COVID-19. They had worse outcomes in general if you're over 65. And there was worse outcomes if you had chronic conditions like heart, lung, diabetes, obesity, which applied to many older adults with IDD, and many cases in long-term care settings. So that was a real disaster for long-term care settings. Next slide. So what do we do about this? Certainly greater knowledge about impairments and treatments. So any kind of training about that is really important, because we know that families and people with disabilities need more information, providers, but also the professionals that work with them. Certainly reduction in poverty and unhealthy environments, that may be a little harder for us to address. Improved health behaviors through health literacy and health promotion, and I'll probably focus on that the most. And improved access, accessibility, equity, and effectiveness of healthcare, and all that will result in better health and fitness in later life. Next slide. So I'm going to focus on the Health Matters, exercise, nutrition, and health education curriculum for people with DD. So, that's one example of one that's considered evidence-based by the Administration for Community Living. Living Well with a Disability is another one that came out of University of Montana. And recently, we've been doing the We Walk, which is, I would say, more in the pilot stages of research. Next one. What this slide shows you, and I'll get into more detail, is how we develop the Health Matters to become a real scale-up. Because you can develop curriculums and they just sit on the shelf, they don't go anywhere, nothing happens with it after some funding is over. So we had some basic funding that helped us do clinical trials, and it was very elaborate with randomized kinds of a study, and then we moved to community-based. because what we found is we could train people, but once they went back to their day programs or wherever they were living, nothing changed. It was great while they were in the program, but nothing happened. So then we started working train the trainer at the community-based organizations. And then we realized, you know, we got to get those people trained. And we need to figure out how to do really a scale up and scale up in states. And so we started doing these major scale ups. And so I'll tell you a little more about the program itself. Next slide. So this was the original program that we did. And still the program, it was 1 hour of health education class, 1 hour exercise, 3 days a week, 36 classes. There were all these innovations of a personal notebook, and here's a YouTube of the exercise. I think this was done in Kentucky. Next slide, just to show you some idea. And you'll see a lot of pictures with Down syndrome because the first study was only Down syndrome because it was an easier way to get funding from CDC if you had sort of one group. And it was part of a bigger project that we were doing around exercise for people with disabilities. But it really was about understanding attitudes to exercise and food, nutrition, finding things that they like to do, to get the skills, to support each other. This was such a big part. And then to identify the places in their community. So we really wanted to emphasize adherence to exercise and nutrition. Next slide. We used the stages of behavior change. We had the advantage of working with the Roybal Center on Aging, and in gerontology, it's much more developed in terms of how we think about, theoretical aspects. And here's just an example of, we had people who were at least thinking about it, and so that they were part of it. And then they make the plans, the preparation, and then they're actually doing it. Because when they would first come in, they would have, especially people with Down syndrome, they didn't have a lot of energy to really do it. And they had to learn how to use the machines, etc. And we had exercise physiologists and nutrition specialists, and we had the whole psychologists, nurses. It was this huge program. And then I'm still doing it, maintenance. So and then there's relapse, because if it doesn't keep going, nothing happens. Next stage. Next slide. Here's some of the outcomes in the early studies that we did. They learned about exercise, they had confidence. It was quite focused on exercise in the beginning, but then the nutrition, we emphasized that much more later. Knowledge about exercise, confidence in their ability to exercise, life satisfaction went up. That was an interesting one. And then all these sort of physical fitness kinds of measures, like physical activity, strength and energy, peak VO2, and stair climbing. What was interesting is the caregiver perception of exercise benefits. So that was a big part of it. And then their access barriers went down. So this was the kind of evidence-based study, the first one. Next slide. So when we moved to the Train the Trainer curriculum, it was really to help the community-based organizations do it. And that's really been our emphasis ever since. We don't do exercise program in our building anymore. Next slide. So when we did the Train the Trainer curriculum, what was surprising was that it had a big impact on staff. I was actually surprised because the staff had pretty high obesity rates, but when I looked, it wasn't that different than the general population in the US. But what happened as a result of them getting the Train the Trainer, they improved their energy and pain, they improved their psychological well-being. They became more positive about exercise and nutrition expectations for the people that they were serving. And they really started developing environmental supports for nutrition. Just to give you an example is, if you have a candy machine right there, that's not going to help if you want people to stay out of candy. That's a small kind of thing. Knowledge of the nutrition recommendations. And organizational policies that support health promotion. That's so important. If you go into an agency, we do a whole thing with an inventory of the attitudes in the agency and supports. And we do applications that they actually have to fill out these things. Next slide. And what was the impact on the adults with IDD that then these people went to train? And compared to controls, they showed less pain, increased self-efficacy, and increased social environmental support for exercise and nutrition. So those are just an increased self-efficacy also for exercise and nutrition. So next slide. So what's happened now, and I think COVID probably helped this happen, is, and this is Beth Marks and Yasmina Sisarak are now doing a lot of this work. They've really taken over this whole project. And you can also look up the Health Matters program and read about it. And they've developed a virtual coach. So everything is virtual now. So they have these master trainers that it's 6 hours online, and it's how to really start a career, how to really start and to do health promotion at your own sites. And it has adaptable instructor scripts, participant handouts and worksheets, 59 lessons on health, exercise, nutrition, choice making, self-determination. The actual program that then gets implemented is a 12-week Healthmatic program with group physical activity and education and 36 lessons 3 times per week, 4 to 6 hours weekly. The classroom now has a virtual coach aspect to it, which is a multimodal supplement to the curriculum with 36 lessons, and virtual support allows for interactive communication, feedback, resource sharing, and collaborative learning. So this is how the virtual coach works. And they've been doing it all over. Next slide will show you. So its reach since 2020, since doing the virtual, is 8 countries and 8 states, 147 community-based organizations, 10,000 participants with IDD, and 2,800 community-based staff. So it's an example of how you can really do reach that's in a bigger way, where you start out with an evidence-based curriculum. So there's a lot of states that have gotten funding to do this kind of thing, which is how they've been able to do some of it statewide. Next slide. Another program is the We Walk program, and that's a 12-week technology intervention to improve the physical activity of adults with ID and their family caregivers. So they actually learn to walk together. But what's unique about this one is the use of technology, using Fitbit and text messages and individualized kinds of that gets sent to people. That's very individualized. And here we've been able to use technology to do all that kind of thing. And we have found an increase in moderate and vigorous physical activity. So that's another example of a program where you don't need fancy equipment and you do a walking program. Well, places like North Dakota are kind of cold, so you walk in a mall. You can walk, it doesn't have to be outside. Next slide. So those are just 2 examples of some health promotion programs. Some key issues in healthcare, that whole issue of rationing of healthcare for older and disabled. Think about like organ transplants or dialysis. Who gets it? The criteria that's used is years of life expectancy, number 1. Well, if you have Down syndrome and your life expectancy is at least 10 years less, then if you're a 60-year-old person or a 50-year-old, you may get denied because they say you don't have a lot of life expectancy. Ability to keep the regimen, they may say, well, you can't follow the instructions very well. Well, a key is the amount of support available if there's other people around to help. And will these interventions improve quality of life, balanced with the burden for the person in cares? I don't have an answer, but these are the ethical dilemmas that people have. Next slide. The use of health checks and preventive screening. Again, there's always in public health, you look at the risk versus the benefits. And what's important is the equality of access. And then how do we do patient-centered care and health literacy if people don't really know? So you really do need some health literacy education for people with disabilities and their families. Professionals need to have more time for listening. And sometimes that's hard because the physicians or the other health professionals are very busy. Care involvement is key. Very important. They see a parent or a support person coming in makes a huge difference. And then there's the case of generic versus specialized services. I was involved in a legal proceeding that happened where there was a woman with Down syndrome who lived with her mother, and she was like 50 years old or something. The mother broke her hip and couldn't take care of her for a short time. While she was in rehab, she put her in a nursing home. The nursing home saw that she was obese, and they thought she was obese and put her on a 1,200 calorie diet. What happened is she developed pica, which means you eat everything in sight, including her clothes, like whatever she could get a hold of. She was so hungry all the time. And eventually she died. They had her naked, and I mean, it was just bad. And I was on the side, saying that these were bad services. And there was a head of a Ivy League gerontology university, a gerontology department who said it was good care. And I saw that there was some psychologist that had written, or some professional written in, these people don't learn, you can't use behavioral techniques on them because someone suggested some behavioral techniques. So I was really quite appalled about that. So it just gives you an idea when people don't know. I'll give you an example where with my sister, she had a very bad accident. She was hit by a truck, and she was in a nursing home for a short time. And she called me, and she had infection on her behind from being dragged there. She developed an ulcer cell there. And she called me in the morning at 9 o'clock to say that she had a bowel movement, nobody was coming. And she was crying. At 12 o'clock, she called me and said, they still haven't come. Now, you know what can happen. You already have an infection there. And I called the nurse there. And what I got is, those people have no sense of time. I said, well, I have a PhD, and I saw she called me at 9, and now it's 12. Okay. So this is just an example of why it's important to have an advocate and know your rights and all those things. The factors associated with disparities. This is some research that we did around managed care and looking at surveys that we had. Certainly having worse health status, living in institutional settings, having more unmet transportation needs. That's an important part too. Being a racial ethnic minority, in a lot of research we see that. Having a physical disability in addition, having less family involvement, and poorer care coordination. And again, the way the care coordination is done is also very important. Next slide. Here's an example of a My Health Passport, which is really great. This is from the University of North Florida. And this is nice because you just have like a 1 or 2 pages. It tells about the person. So you come in, let's say you have an adult with that is autistic, that, people need to know how to treat that person or what meds the person is on. So they have it right away, right there. Next slide. This is a documentary called None of Us Want to Stand Still that came out of Rush University and Georgetown University Center. And it has voice of the advocates who share their stories about how changes can be made on all levels of a healthcare organization. So I put the link here. Next. I'm going to switch to a different topic now in terms of families and long-term services and supports. And so you'll see all kinds of information on here about families and how we support people as they're aging. Well, we know that they're more likely to live with parents and that 24% live with caregivers 60 and over, and there's another 38, I think, percent that are in that next age group. So it's going to be a big need. We know that. And often people need long-term service supports lifelong. We have long waiting lists for home and community-based services. You know, the risk data from University of Minnesota always has updates on that, but the latest is about 500,000, but that a lot of people don't even bother getting on the waiting list. And then families and persons with disabilities need to engage in future planning, and I'll be talking more about that. Next slide. This just shows you that only about 10% of families actually receive any kind of formal support from the service system. Next slide. So where do people live? We were talking about how 60% live in a family home, and that's the majority. And we still have some in institutions, especially in my state, in Illinois, 16% in group homes, and 11% their own home, and 5% a family home. Next slide. So what does that mean for families? What's some of the impacts? Some data, especially from University of Wisconsin, shows fewer opportunities for employment, a restricted social network. We see impact on the physical and mental health and stress for some groups, especially for certain racial ethnic groups that have less resources. And there's greater difficulties as parents and the person with IDD age, as they age together, and especially if the person with IDD ages a little earlier. But caring also has its very positive aspects. I know in research that I've done, 90% of families say caring for their relative brings meaning to their life. So it's not only the negative aspects, and sometimes a person with disabilities caring for their older parent as well. Next slide. We have many unmet family support needs, as we showed that so few families, less than 20% get any kind of support. The role of families is much more formalized in schools, where you have the individual education plans and a lot of mandates about families. Out of one of the studies that we did, unmet service needs reported by families, over 2/3 needed respite, meal services, and support groups. And over half needed training or education for future planning, home mods. Half needed home health care and assistive technology. These are just some examples. There's been needs assessments in many different states. Next slide. I know there's also been the FIND survey that's coming out of the University of Minnesota that also has been doing needs assessments. Well, we know that family support makes public health and financial sense in the long run. There's huge costs for families of caring for a person with disability, over 28% of extra costs. But we also find that when we look in the research that family support has resulted in better family quality of life, more caregiving satisfaction, less stress, and less caregiving burden, and more self-efficacy in helping the family member with disability. And so this is just an example, and it's also associated with a decreased mental health. When you have unmet service needs, you have worse mental health for the female family cares. And where it saves money is that it also prevents institutionalization. So that's a really big factor as well. And we do know that psychoeducation interventions have shown very positive effects for families. So I will give you some example of one of the ones that we've been working on. Next. So how do we support families? Well, there's a lot of public policies like cash subsidies. Again, we know that not that many families get that, but it does have a big benefit. And then consumer directed supports. And often we find, in one of the studies we did, at least half of the families had one of the parents was actually the person getting the consumer directed support money to help. They were like they were the personal support worker for their family member. Psychosocial interventions like support groups, future planning interventions, any kind of support coordination is also really important. And then natural community and informal supports. And, that's a Charting the Life course does a lot of that. And I don't know if North Dakota is part of Charting the Life course, but that's out of the University of Missouri. And they've been doing a lot of work for families that aren't necessarily in the Medicaid system, getting all these family supports. Next slide. Well, we know that families need to plan for future needs. And sometimes there's so many barriers because families are unaware of the legal and financial options. And we know that if you don't do it correctly, the state will end up taking back, any funds that you have for all the Medicaid services they've given you all the years. But people fear the unknown, and maybe they don't know what's out there. And they also don't know who may take over. They'll say, no one can do it like a parent, or I don't want to burden my son or daughter, my other ones. And there's some mistrust and lack of aging and disability service system collaboration. So, and then people just, they procrastinate because they have other age-related needs. And actually, in the general population, thinking a whole lot about the time when you're not going to be able to take care of yourself and all that actually produces a lot of anxiety in general. Next slide. This is a sad slide of what happens when families are very worried and unaware of options and don't do planning. I wish my child dies 4 minutes before I do. This was a statement made in one of the focus groups that I did. And then I found out, not only did my own father say that when my sister was in a dire condition, and he very much loved her, but I heard about that what happened is that both of these incidents in Elmhurst and both of these in the Chicago area, a parent kills his son, his daughter, his wife, and himself. And this was actually an article that was in the New York Times, and I know I had been interviewed about that. So why would he do that? And then in this other picture, this woman who had adopted a child with cerebral palsy and took really good care of this child, she also killed her son, her daughter, because she herself had cancer and she was worried of what would happen. And so she was actually found guilty of involuntary manslaughter, but people thought that she shouldn't have to pay because they didn't think the quality of life of a disabled person because that she did anything wrong. So it was very controversial. So let's hear about some good cases. Next slide. What happens when you do it right? So here's an example of a curriculum that we developed that's evidence-based, called The Future is Now. And it was developed over a period of many years because we tried so many different things and families couldn't seem to make plans, or they did, and we tried different approaches, and we worked with people with disabilities and families. And finally, we developed this, and it was really to help families develop planning goals together with their family member with disabilities. And as a result of going through this, and this was an evidence-based originally, they experienced less burden, less worry about the future. The persons with IDD had greater voice in decisions about their life. And we started this quite a while ago. Next slide. This just shows you aspects of the curriculum, identifying your dreams and nightmares, which becomes a really important thing. And you really have to understand the culture of families and what their support networks are in building it. What are the desired living arrangements? What about education, work, retirement? A lot of people with IDD want to continue working because it provides meaning to their life. Who's going to be the succession person? Next slide. Some unique features are the integration of both person-centered and family-centered philosophies and approaches. You know, it's not always the same what the family wants, what the person wants, and what different people in the families want. So it's a lot of problem solving around that. There's peer support, both peer trainers with disabilities and families with disabilities. And then it's really not just looking at what's out there, but how you can help make things happen. And now we're doing the virtual training, VFIN. Next. We tried to get funding for that for several years, couldn't get it till COVID happened. Next slide. So we've been doing this virtual train the trainers. We did it with the ARC originally, but now we're doing in Zoom with real-time interactive sessions. Our most recent has been in Kansas, Illinois, and California. California really took it on. They had some special funds through an aging initiative, and we did it with the ARC of California and had 15 trainers. They trained 1,000 participants. Plus they gave us a Spanish version. Recently, we got a Family Support Research and Training Center from the National Institute on Disability and Independent Living and Rehabilitation Research. And we're doing everything virtually and working with US Aging as well on doing a totally Zoom versions of everything. So next slide. This is a picture of my mother and my sister and me with my 2 siblings, my sister and my brother. Why? Because we're going to talk about siblings and the importance of siblings. Next slide. Which, by the way, my sister, who was in such dire condition, is now doing very well. So it's a good outcome. And she does have good plans in place. So I actually co-founded the Sibling Leadership Network, which now has over 5,500 siblings and supporters involved, 28 state chapters. We started it in 2007, and you can get on and read about that. And it's really with and for really advocating with and for siblings with disabilities. Next. And what I'd like to end is thinking about how do we bridge aging and disability? Because we know we can contribute to each other. We have common needs, and we certainly can get a lot further. Look right now, what's going on with advocacy around different disability policies. Aging and disability have banded together to stop a recent initiative around freezing funds. That's a picture of the Chicago Bridge, by the way, just next to my building. Next. Next slide. So we know there's a lot of challenges because of the services have always been so segmented. Of course, now we have the Administration for Community Living, including aging and disability. But we still have different philosophies and terms and definitions and very distinct fields. You don't see a lot of bridging. Which I'm very happy that we'll be having some special issues on this topic in the gerontologist. And then, you know, people want to protect and they don't want duplication of funds. And so we know because of that, there's missed opportunities. Next slide. So one thing you can do is adapt from aging, like doing geriatric assessments. There's a falls prevention program that's called the Otago, and there was a version that was made for people with IDD. The same thing with the chronic disease self-management. There's an evidence-based one that's been developed for a general population, but in the University of Albany, they did an adaptation for developmental disabilities around diabetes. And then anything to do with making environment accessible can be both for people who are aging and disability. Next slide. To wrap up. What I do want to tell you is about the new initiative by the National Association of Councils on DD, Bridging Aging and Disability, that we are a big part of. And there's 17 state projects where they need to do projects with aging and disability. And there's Joe Caldwell from Brandeis put together Emerging and Promising Practices report that includes a lot of what these different states are doing, plus other best practices in aging and DD. And I put that up here if you're interested in looking at it. And just some examples are, I'm using the Charting Life course 3 categories here to talk about it. Information and referral and navigation is some states are doing, each states are doing all different things of what they want to do. They're getting funds, small amount of funds to do different projects. So cross training, one of the states is doing no wrong door, trying to have one place for people to go to get information, connecting and networking. So peer support, future planning, those are the kinds of things there that some states are doing. We're working with a couple states and doing the future is now. And then services and policy, there's quite a few that are doing disaster preparedness, changing guardianship, changing intake forms. So the intake forms that aging uses includes something about IDD. Next slide. Just very briefly, we have the National Task Group on ID and Dementia Practices. And I have the website up here, and I don't have time to go into detail, but that group has been amazing. And they have a curriculum, they do workshops, they have master trainers, they've been getting federal funds. A lot of the dementia projects have included the NTG as part of it. So that's an amazing resource, and they've become their own not-for-profit. Next. So looking to the future. So what are some recommendations? So what I have is certainly the greater use of technology and universal design to address age-related changes. So what all these things that are helping people with disability, they also help older people. Transportation assistance, especially I know North Dakota is very rural. So that becomes really important. The pressure on the system and the families when there's a lack of the workforce, I think, and I know that the North Dakota USED has some good training in that. And also community capacity. So we know we have a crisis in the direct support professional and the lack of it. And I also know that there's a growing recognition of supportive decision-making and interdependence and, you know, how we work together in that. And we need more research on better ways to bridge aging and IDD because we really can be a resource to each other in advocacy and research and policies. Thank you. And I'm open to questions. And you can contact me.
Thank you, Tamar, so much for that great presentation. Does anyone have any questions? If you want to raise your hand or if there's anything in the chat.
Somebody asked, what is IDD? Sorry about that, intellectual and developmental disabilities.
There is one question in the chat. Health Matters is a pre-approved self-supported program for funding opportunities. Is there a movement for it to become a pre-approved CDSME?
What do you mean by CDSME?
This is me, Carrie. I am at the center here in Minot. So like, for instance, there was just a funding opportunity for aging with HHS, and part of the funding opportunity, you have to work with both an organization in their Appendix B, which is the CDMSE, and Appendix C, which are self-supports. And so we always have difficulty because in the Appendix B, the CDMSEs, there's really none that are IDD inclusive. So
You know, it's sanctioned by CDC and by ACL.
yeah, but no, they have, I know,
Yeah.
and this is an ACL, like, but it's sanctioned in Appendix C of all the funding opportunities as a self-managed support program versus the CDSMEs, which are different and more chronic disease, self-management things. But there is none ever on that list of pre-approved that are inclusive of IDD populations. And so we run in this vicious circle, right, of not being able to apply for funding that would help our community in aging because there is not an organization we can partner with that is on the list.
You know what? I would write to Beth Marks and Yasmina Sisarak. You can and ask about that, and I'll ask them as well.
Okay. Maybe Dr. Heller, I'll send you
Beth Marks, she's one of our faculty, and you can probably also contact her on the link that I gave for the Health Matters.
Okay.
Should have all her contact information, but if you need it, I can certainly send it, because I know that people have included it in their grants from ACL and CDC grants. So you would think that it would be approved.
Yeah, on both lists, because there's a couple of entities that are on both lists, but Health Matters is just...
Because if they're not, they should find out how to get on it.
Exactly. That's why I asked, is there a movement for it? Because like that would be so helpful for those of us in the community that want to, go after these big fundings from HHS for aging issues.
Well, I know that NTG is included in lots of the National Task Group on Dementia and ID is included in lots of the dementia grants. And there was an aging grant where they approved the Futures Now, but we're not on the list. So, I'm not quite sure exactly.
I'll reach out to Dr. Marks and see if there's because it would be really a godsend if that was to happen.
Yeah, that'd be great.
Thank you.
Somebody asked about nonverbal. That's a good question. Yeah, right. I'm not sure. Are you thinking about like for the Future Is Now resource, if we've had any nonverbal? What we have had is sometimes the family doesn't bring the person, doesn't have the person participate. We've had that, and they'll say, oh, they can't. And if they don't know how, I think the issue is the accessibility. And because it's virtual, we can have the accessibility where they don't have to read anything, where they can listen. But if they're not able to communicate with writing, or that'd be hard, but they still can acknowledge what they want. And so we do talk about that, you know. It reminds me of what happened in the late 90s, 1990s. We put together a session. It was kind of the first of its kind that combined self-advocacy from aging, intellectual and developmental disabilities, physical disabilities, and mental health. I think it was like 1996. And it was in Washington. And boy, was that contentious, because somebody, there were some people from the mental health who said, why are parents here? We don't want parents. Or another one said, no parents. And then a person with IDD got up and started crying and said to my mother, I love my mother, she helps me so much. And then there was someone from the IDD, you know, very big proponent of self-determination, got up and said, all you need to do is give people with IDD money and let them make the decisions. So then Sue Swenson, who at the time was the ADD, she was either the ADD commissioner or the head of the ARC and the US ARC, she said, you know, Tia Nellis, who's a well-known advocate, told me I should bring my son Charlie. I've never brought Charlie to anything before. And I gave him the agenda. Do you know what he did with it? He ate the agenda. But I do give him choices. And he is nonverbal, but I know what he likes to eat. He'll show me what he likes to eat. He'll show me what he likes to do. And that's the way I find out what he wants. So some people thought she was disrespectful, but other people understood what she was talking about. So I hope that answers your question about how you can think about those issues. And I think it's all part of supported decision-making too, is how are you able to tell what people want? I see the time is getting close. Yeah, right.
Yes, so if you have any questions, I think definitely email. But thank you so much, Tamar, for today. This was great. And thank you to everyone for attending today's webinar. We hope you enjoyed today's content. We'd appreciate your feedback via an online survey, so see the link in the chat. Certificates of attendance will be emailed to all participants who complete the survey. And certificates will be issued within a week of each session. So once again, thank you so much for your participation. If you'd like to join us again next week, we have Lori Cooney from the Institute of Community Inclusion at UMass Boston will present on inclusive instructional strategies using AI. So stay in touch with NDCPD by liking us on Facebook or checking out our website. And I hope everyone has a great rest of your week. Thank you so much, everyone.
Bye. Thank you, everyone.